depending on where you live, distress syndrome. Okay, so ARDS, we've recognized in the last 5 years, really, last 10 years, that it's really a significant cause of mortality and very hard to take care of. So it's gone through a lot of name changes. We didn't know what to call it. So non-cardiogenic pulmonary edema. So in other words, not heart failure. The lungs are wet, but it's not heart failure. It's not caused from a heart problem. It's not caused by, if you had cor pulmonale yet?
Yeah.
Okay, it's not caused by cor pulmonale. It's, maybe it's cor pulmonale. It's not caused by that backup in the lungs. It's also been called adult hyaline membrane disease, like neonatal. In other words, the surfactant in your lungs doesn't work, and your lungs get wet. Capillary leak, same reason. The capillaries leak. You get decreased hydrostatic pressure. What are the two pressures in the capillaries that keep blood where blood's supposed to be? Right? You're supposed to have blood and fluid in your vein, right? Good. Lung. Bad. Okay? So what are the things that keep fluid here and don't let it go there? There's two pressures.
Hydrostatic and
Hydrostatic, which is the push. So you can have increased hydrostatic from here, meaning more of a push here, or you can have not enough push in the lung, pushing back. And that allows fluid to seep in. What's the other one?
osmotic.
Osmotic or oncotic. So people who are cirrhotic, they're not making protein in the liver, they have less albumin here. And so the water or the fluid likes the protein. As soon as the protein goes away, the fluid goes away. So most of this is hydrostatic problems in the lung. But the capillary leak syndrome is caused by a little bit of both. Or called shock lung, because we found people who were in sepsis often had concomitant ARDS. Now it's all wrapped up into ARDS. There's two types of ARDS. There's ALI, which is acute lung injury, and there's ARDS, which is a severe form of that. So like we were just talking about, it's a syndrome of inflammation and increased permeability that is associated with a constellation of clinical radiographic and physiologic abnormalities that cannot be explained but may coexist with left atrial or pulmonary hypertension. So in other words, your lungs are failing. And ARDS is just a severe form of that. You can actually compute it, how hypoxic they are. If their arterial oxygen and their FiO2 is greater than or equal to 300, they're just acute lung injury. As they get more hypoxic, you go into ARDS. It's pretty simple. ARDS is just bad ALI. I've never diagnosed them with ALI. I've diagnosed a lot of ARDS because I don't calculate this stuff. I go, oh, you're wet and sick. You have ARDS. So there's no difference. They're treated the same way. They look the same. So sometimes they might ask you, not me, not next time, about ALI. It's just pre-ARDS. So, all right. So ARDS is the end spectrum of acute lung injury that we talked about. The hypoxemia is worse. It develops rapidly, 4 to 48 hours, so very quickly. And we have diffuse alveolar damage. That's a big deal. Diffuse alveolar damage. This is the Berlin definition. Again, who cares? You know if they're wet and it's not from their heart, they have ARDS. So this is what it looks like. Okay, black good, white bad in the lung. Right? Okay. So you get this diffuse bilateral fluid pattern. So this is ARDS. This is bad ARDS. Maybe this is ALI, not as bad yet. You haven't had complete capillary leak like you've had here. I don't know. You'd have to calculate the PaO2, FiO2. This is ARDS, white lungs, yucky, bilateral alveolar interstitial disease. Okay, bad, bad. This is a kid with ARDS. Hyaline membrane disease is a type of ARDS, right? So prenatal or neonatal respiratory distress from inefficient or insufficient surfactant. So these are all ARDS. Yeah, and pretty easy, right? I mean, you got this massive white everywhere. So it's this diffuse alveolar damage, okay? So we're looking at, it's not super common, but we're recognizing it more. 60 per 10,000 people. But we know that about 20% of those in the ICU for any reason. So you go into the ICU for a GI bleed, an MI, whatever. About 20% of the ICU meet criteria for ARDS. And it has a pretty significant morbidity and mortality, right? So 26 to 44%. I love big ranges like that. It's like, who does these studies? That's a big range, but yeah, it's sick. 80% of the deaths, though, are not because of their lungs. It's because of the kidney shutting down, shock liver, things like that. So people don't die necessarily just from the lung injury. They die from all the complications of it. Gosh, what are the risk factors? Well, it's like we're doing influenza again. Extremes of age, pre-existing organ problems like cirrhosis or dialysis, things like that, and other chronic medical problems. So, however, we do know, if you get ARDS because of a lung problem, pneumonia, pulmonary contusion from an accident, something like that. If you get ARDS from a pulmonary acute lung injury, not from something else, you're not in sepsis, you're not on dialysis, whatever else. If you get it from a direct lung injury, we know that they have a much higher risk of death. So pneumonia that develops SARS, bad. Sepsis that develops SARS, not as bad. Better chance of living. Maybe that's the big range there. But we know that extrapulmonary has a better outcome. All right. So here are the causes of ARDS, right? Pneumonia by far is the biggest. That's a direct lung injury. Aspiration, direct lung injury. Trauma can be either, right? Severe sepsis is not a direct lung injury. And that's almost a quarter, or over a quarter. You could have pancreatitis, near drowning, salicylate poisoning, which I was talking to someone about. I hate salicylate poisoning. Don't take aspirin to kill yourself. It's a horrible way to die. It is. It's almost as bad as Tylenol. Narcotics. So smoke and chemical, you'll see that a lot in people who are in industrial accidents or in fires, house fires. They get direct lung injury from the smoke. They get pneumonitis and they develop ARDS. Okay, so here's the, pathophys. This is where I went to sleep when I was a student. I hated pathophys. But what you get is you get a direct or indirect lung injury to the actual alveolus. It releases, hey, look at that, pro-inflammatory cytokines. This is why influenza and ARDS have overlapping and why I get to talk about all this stuff. You have a cytokine storm. All of these inflammatory molecules that are in here cause capillary leak, okay? So cytokines attract neutrophils, they attack all the other pro-inflammatory markers, and you get damage to that basement membrane, that ACN membrane, that alveolar capillary membrane, the one that keeps good from good and bad from bad. Once that's lost, once that basement membrane is lost, you get this proteinaceous fluid coming in. Surfactant, we all know what surfactant is, right? It's like dish soap, keeps things nice and slippery and loose. The surfactant begins to break down in the presence of all this proteinaceous material. And then, surfactant keeps the alveoli open, it begins to collapse. The alveoli collapse, okay? Oh, look at all those. I didn't know those there. Okay, so what happens is you get three problems. First, you can't exchange your gas. You breathe in oxygen, but it doesn't get across that capillary membrane to the blood. So you have a VQ mismatch, right? V is ventilation, Q is perfusion. So you're breathing, but you're not perfusing. You're not getting oxygen to your blood. You get shunting. So shunting, you know what shunting is in pulmonary, right? So you get areas of the lung, well, look at this. So this is the lung. You get areas that are full of fluid. You get your blood flow. When the blood flow goes through here, it's shunted. It doesn't pick up any oxygen. So you get this shunted blood. You get essentially continuous venous blood going through those bad areas of lung. So it hasn't redone its perfusion. So you get a real problem with perfusion and diffusion. The oxygen can't diffuse across this eliminated membrane. So you'll see what happens. You get higher CO. You get a problem with CO2 because you're not returning it to the lung. You're not picking it up. Has more dead space. Then the other problem is you have a problem with compliance. We talked about this in ventilation with peak and plateau pressures. If you have an alveolus full of fluid, that is much harder to ventilate than an alveolus that's full of air. So you're working against stiff, non-aerated, collapsed, atelectic lungs. Okay? And so it's requiring more and more pressure to deliver the same tidal volume. And then you get cor pulmonale, right? You get left ventricular problems, you get right atrial problems, as it pushes across this preload and afterload problems. All right. You guys know about Swan-Ganz catheters?
Yeah.
We don't use them anymore. But you used to float this catheter into the atrium, measure the pressure in the right atrium and the left atrium, pulmonary wedge pressure and all this. We found out that it's really high. It's not good. We don't do it anymore much. So we don't really measure it, but you get this increased pulmonary arterial pressure. All right, so how do you treat ARDS? Well, it's simple. Take care of the problem. Okay? If they got pneumonia, treat the pneumonia. Give them antibiotics. If they've got sepsis, find the source, treat the sepsis. We typically use a low tidal volume. Okay? What we don't want to do is over-distend, and we'll look. Oh, there it is. So this is why we use low tidal volumes. This is not a homogeneous problem. This is a heterogeneous. You have good alveoli. You've got somewhat good alveoli, where if I can increase the hydrostatic pressure, if I can put a little pressure, I can push that fluid back out. And then you've got just damaged alveoli that are no good at all. They don't participate in any way in gas exchange. So we want to use low tidal volumes to not over-distend the lung. If I use a tidal volume based on the lung, a full lung, and only half of it's getting ventilated, that means all that volume is going to that part of that lung. So you're going to over-distend those alveoli and get pneumothorax, things like that. We're going to use PEEP, and I'll show you why in a second. We're going to keep those alveoli open. Again, the hardest part is blowing the balloon up as the first breath. If you, and then let go, the air comes out, and you go, oh crap, I gotta do it again. Like my kids, right? They hand me the balloon, and they let go of it, and then before I can tie it. Then they go, oh, I gotta do it again? So PEEP keeps the balloon blowed up. Blowed up, man. History, not English. Keeps the balloon blowed up. We want to monitor those airway pressures. We don't want them to get over 30 of peak, or 30 of plateau, or 35 of peak. Conservative fluid management. So septic patients need fluid, but nobody else does. If you give them too much fluid, it's only going to go one place. It's going to go in the lungs. And then any kind of potential complications. So people who are intubated and laid down, they get aspiration from gastric contents coming up. They get stress ulcers. We want to reduce all those other complications. So here's how we do it. So this is all from the ARDS net. You'll see at the bottom of that title, the Acute Respiratory Distress Syndrome Network, ARDS net. So they put out a ton. I think they owned the New England Journal for about 6 months, just putting out paper after paper. So they looked at patients with ARDS, small tidal volumes. Instead of the 8 to 12, doing 4 to 6, and they used 6. It decreased mortality. It increased the number of ventilator-free days, the change you had coming off the ventilator. And it decreased extrapulmonary. Remember those patients? They're dying for other reasons. So they might have worse thoughts. Their PO2 might look worse because you're not ventilating with high volumes. That's okay. We're permitting some hypercapnia. And they have a lower pH. They're a little acidotic. You can treat that with fluids rather than ventilation. And that we talked about right there. Why? We don't want to overextend it. We want to use some PEEP. So they said PEEP, that positive end expiratory pressure, a dog out the window. If you give patients PEEP, they'll do better. That's their hypothesis, and it was true. We found that we want to recruit alveoli. We don't want to spend all of our air into the good alveolus and then take it away, and then put it out, take it away. It's called recruitment and de-recruitment. We want to minimize that. So hopefully this is going to be it. We'll show you what PEEP looks like. No? No. Is this connecting to your head? It is! That is not your lungs, don't worry. That is pig lungs, which are the best we can do. So, let's just take a look at PEEP.
You have a recording again. This is a different.
There's no PEEP. Back down.
And on short Zeep,
Or inspiration,
we're going to go to 15 of
expiration with no PEEP. Now we're going to move up. This is 5 of PEEP. 5 of PEEP. No more than 5. Notice the lung does not recollapse. You're not re-blowing it up. So this is PEEP. We're keeping PEEP on the whole time. So they're getting 5 centimeters of water pressure. Uh-oh, there we go, there's normal respiration.
Okay,
Down.
complete recruitment.
Goes. So we're not totally collapsing. We don't have to re-blow up every one of those alveoli. Then they take PEEP away. If you take PEEP away for one breath, that's what happens. You've got to rebuild up. So we will bag people. We have a little PEEP meter on our BVM. We set it on 5, we bag them,
See some of
we
the.
get them up.
some
If I
of
didn't
the,
take it off and put them on the
portions
ventilator,
are
they've lost their PEEP right there.
still, even
Their lung goes,
inspiration.
all their alveoli collapse again. And I gotta overcome all that again. So PEEP is good. Too much PEEP will blow it out. Will blow out your alveoli. But PEEP is good. So we use 5 to 10 of PEEP on all patients. So PEEP. So we want to increase the alveolar recruitment without hyperinflating the alveolus. And we found if we can get to a plateau pressure around 30, not over it, that's a good level of PEEP. That's usually about 10 of PEEP. All right. Here's the ARDS-NET table. This is in every ER, ICU, everywhere. Because this is what they came up with. They came up with a mix of increasing the FiO2 and the PEEP to keep the PEEP up. If people were hypoxic, they said, hey, don't ventilate them more. Don't use more volume. Turn up the FiO2, turn up the PEEP, and they'll be able to ventilate better. If you're hypoxic at 80, don't just breathe more. Don't breathe deeper. Use PEEP to keep open what's open, and turn up the FiO2 to get more oxygen in. That was their findings. So these charts are everywhere now, these ARDS-NET charts, on how to keep these people ventilated and oxygenated without overdoing it. We don't want to hurt that damaged lung. So again, we want that plateau pressure to be 30-ish, around 30 or less. We don't want overdistension, we don't want lung strains. And remember, sometimes you're going to have higher plateau pressure because your peak pressure is higher. The person's obese, they're pregnant, they have other extrapulmonary problems. So your peak pressure might be a little higher, raises your plateau pressure a little bit. All right, this is what it looks like again. This is a better graph than one in the other place. You have that inspiratory pressure, it drops off to a plateau pressure, and then we want to hold some pressure with PEEP. We don't want it to drop back down to 0. We want to keep some airway pressure. So that graph doesn't go all the way back down. It goes down to a level of PEEP and then comes back up. All right, fluid management. Fluid management. Give them fluids if they need it. Don't if they don't. If they have too much diuresis. Really simple. So increase lung water, that rush of capillary permeability and leakage is what causes a lot of these problems. So if we don't need the fluid, don't give it. If they're all wet, try to dry them out with diuresis. So after shock is resolved, you should make an effort to diurese. It's pretty simple. So this is one of the coolest things we've learned in the last few years. This was 2013 that this came out. Usually we put a person in bed, we put a tube in there, we sit them up a little bit, we ventilate them. They said, what if you turn the patient over on their face? How about you ventilate them like that? So we started doing that. You put them in the swimmer's position and change it every 8 hours, 6 to 8 hours. So they go really slow, they get a really slow front stroke. Every 6 hours. They don't go very far, but every 6 hours you change it, you put them in the swimmer's position, and their lung is down. And this, we find, increases oxygenation and shortens ICU duration. And you can see that early application decreased both 1 month and 3 month mortality. I've never done this in the ED because I just want to get them out. They actually make a new machine that's like this big rotisserie machine where the bed is on a spit and the bed flips over, the whole bed flips over. And I guess if it was loose, you could just like spin the patient. But the idea is that the patient rotates. It's this big spit, like a rotisserie. And they get locked into it and it turns them over by itself. And it's really quite cool. And I'm sure very expensive. I've never used it. So the easy way to treat ARDS, this capillary leakage, is, oh, there's your ideal body weight formula. I never used it. Somewhere there's a table, you can look it up. Some things you just don't have to remember. And then we give them a low tidal volume, between 4 and 6. Really shouldn't ever be more than 8. We give them, as we talked about early, we want to match their rate to what they were beforehand, so they get the same minute ventilation. If they were breathing 24 times a minute before they went on the vent, start them at about the same, so they get the same minute ventilation. Wean it down as you need to. Turn up your FiO2, turn up your PEEP, don't turn up your tidal volume, just to oxidate them. And it's okay to have a little bit of permissive hypoxia, permissive hypercapnia. We don't have to go for 100%, right? Not everybody's got to fit in the box. You don't have to get to an SaO2 or SpO2 of 100% on the little monitor. It might beep at you because it's an 88, but 88 is fine. That is totally acceptable. We have COPD patients walking around at 80%. They come in, I'm always at 80%. So FiO2 and PEEP to reach it. Don't over-distend the lung. Don't push in more volume. And then, if they're shocky, fix their shock. Once the shock has been resolved, diurese them and get that extra fluid off. And follow the ARDS-NET table for fixing hypoxia. Increase the FiO2, increase the PEEP, those kind of things. It's really simple. ARDS is not difficult. Right? So your questions can't be that difficult. I mean, fluid leaks in, get the fluid out. Pretty simple. Any questions about ARDS? Acute respiratory distress syndrome? Any questions? Any questions at all?
So,
Yeah.
just to clarify, ARDS then is any pulmonary edema that's not from the heart?
Exactly. It cannot be explained by left heart failure. Any pulmonary edema. So that's why you get into that ALI, which is mild, versus ARDS, which is severe. So I just call it all ARDS. When you get fluid in the lung that's not from the heart. There will not be a question asking you to calculate whether it's ALI or ARDS. Find out what the ratio is. Don't memorize the ratio.